Good evening, everyone, and the squirrels in the back there. Okay, thank you very much for that introduction. I'm obviously here to talk about the effects of methamphetamine on neurocognition in current and recovering addicts. I've called it crystal clear cognition because it was a comparative study with non-drug using people, I suppose. Okay. So the first question I always get is, what is methamphetamine? Because it's a big word and nobody really understands it. But it is, if you think about it, has a lot of different names in a lot of different countries. Essentially, most people call it crystal meth, or ice, or glass, or speed is another common name. And like it says there, it's a widely abused and highly addictive, colorless, odorless, and psychoactive sympathetic, which means it acts on the sympathetic branch of the nervous system. So it increases, and this is all very technical, increases extracellular monoamine transmitter levels, and that's important because they are dopamine, norepinephrine, and serotonin. So they're all your feel-good neurotransmitters. So as you can imagine, the desired effects of methamphetamine: alertness, euphoria, and intense euphoria. Euphoria like no other drug has ever provided. Energy and alertness, grandiosity. And by grandiosity, we mean that you feel powerful, invincible, you're able to do whatever you want. People on this drug honestly believe that they can change the world if they just think about it hard enough. Loss of appetite, including a drastic weight loss because of that. People literally lose their appetite for weeks on end when using methamphetamine. And another side effect that most people look for, increased libido or hypersexuality. So people are literally ravenous for sex. They also have an enhanced sexual pleasure on the drug. So as you can imagine, methamphetamine use is directly proportional to the increase of AIDS in South Africa. Okay, unfortunately it has some negative symptoms. Now for you and I reading this, they would outweigh the positive ones, but obviously not for a lot of methamphetamine addicts. Hypertension, okay, increased blood pressure, not too bad. Respiratory problems, all right. But then heart complications, and by complications I mean you can have a heart attack and die. Malnutrition, because like we said, there's a loss of appetite and drastic weight loss, so people literally don't eat. Disorientation, not aware of where you are, not aware of what's going on, unable to cope with your surroundings. Insomnia, because it's alert, you can stay up for literally 1 week. Hyperflexia or athetosis. Now hyperflexia is involuntary muscle movements, and athetosis is strange muscle jerking movements. And you'll notice a lot with methamphetamine users, they twitch, they jerk, their faces twitch, they walk like something's controlling them in a different speed than we work. Bruxism, which is grinding of your teeth, which is very common with amphetamines. Hallucinations of formication. Now formication is when you feel that there are bugs or insects underneath your skin. And you'll notice a lot with methamphetamine users, and we'll see in some photos coming up, that they scratch and pick at their skin a lot. And they end up with horrific wounds all over their body because they feel that things are living inside their skin. Rage, uncontrollable rage. Paranoia. Paranoia to the point where people honestly feel that they are being followed or that everybody's out to get them, and this can lead to psychosis. Psychosis on the level of schizophrenia. And often people have a psychotic break on methamphetamine only to discover that they had dormant schizophrenic tendencies and are now stuck with schizophrenia for the rest of their life, as well as having a methamphetamine dependence. So, like I said, it's called speed, chalk, tina, crystal, meth, ice, crank, glass, and in South Africa it's called tik. It can be snorted, smoked, injected, or taken orally. Whatever method you choose to use it, it has a different result. So the slower methods like snorting and taking orally, you get a slower high, lasts longer, it's a little bit more mellow, and by mellow I mean it's not mellow at all, but it's not as intense. Smoking and injecting are the most intense rush forms of methamphetamine, but they're also the most addictive. And your tolerance develops quickly. So here we have what we call metamorphosis, and this woman's been on meth from anything from 3 months to 1 year. So it doesn't take long for your entire existence to change. Okay, 10 million people aged 10 years and older have abused methamphetamine during their lifetimes, and that's from the National Institute on Drug Use. And over 35 million people have regularly used or abused amphetamine since 1996. And this is the important part, making it the second most commonly used illicit drug after cannabis. It has overtaken heroin. Heroin was always everybody's big keyword in drugs. Heroin's such a problem. Heroin has fallen by the wayside. Methamphetamine and amphetamines have taken over. Okay, South Africa is experiencing a methamphetamine abuse crisis, and Cape Town in particular has the highest proportion of methamphetamine addiction in the world. Now, if methamphetamine is now the second most addictive substance in the world, that means South Africa plays a key part in that addiction. And like you can see at the bottom, 41.5% increase in methamphetamine as the primary drug of abuse from 2002 to 2006 in Cape Town. The reason we focus on Cape Town is Cape Town has a very poor population living in the Cape Flats, and it's very easily accessible and very cheap there. It's a harbour city. The ingredients they get there, they import them and export them from different countries. It's very cheap. It's about 10 Rand for a straw of methamphetamine. Okay, so why do we care? It's just a drug. Well, Volko said it best: the rapidly escalating abuse of methamphetamine across the world imposes a sense of urgency for understanding its effects on the human brain and its medical consequences. And importantly, studies have found that exposure to methamphetamine is neurotoxic. So literally, it kills your brain. Possible cognitive impairments have been noticed in methamphetamine users. They're slow, they're agitated, they can't concentrate, they're listless. And these may be as a result of neurotoxicity of methamphetamine. However, there's a dearth of international and local literature on the effects of methamphetamine on cognition. Lots of literature exists on the neurotoxicity. PET scans, MRIs, post-mortem, anything you can think of, but not anything on pure cognition alone. And that's why we decided to study it. That's supposed to say AIM, not M, but anyway. It was to ascertain whether there are significant differences in cognitive functioning in the areas of attention, memory, and executive functioning in 3 independent groups. Current users of methamphetamine, as in people who are currently addicted and currently using methamphetamine. Rehabilitating users, they are in recovery programs or treatment programs, and a matched control group. So important to say is that it's an ex post facto design, which means that it is not really ethical to get people addicted to methamphetamine to study them. They tend to frown on that in the research world. So we had to find people who were already addicted to methamphetamine. So we've taken the people as we can find them. And it's not that easy to get people who are drug addicts to talk to you freely without thinking that you're the police. So we have 14 currently using methamphetamine addicts. We got 17 recovering addicts. They were less willing to talk to us than the current addicts for some reason. And then 18 as a control group. Now, they were matched for age, gender, and education. And the current users had to have a minimum of 1 year regular use with a DSM-4 diagnosis of substance abuse or dependence. And the recovering addicts had to have a minimum of 1 month sobriety to ensure that there were no withdrawal symptoms confounding our results. Okay, the test battery, etc., etc. 1 hour self-report questionnaire, mostly to get demographic variables so we could match them properly. Also, our inclusion and exclusion criteria were in this questionnaire, and we interviewed a lot more people than we actually used in the study. So it was a paper and pencil test. We assessed attention with those tests, memory with those tests, and executive functioning. From attention, we assessed focused attention or concentration, flexibility of thinking, vigilance, tracking speed, and motor coordination. Memory, visual storage, recall or recognition, visual acquisition and retention, intermediate memory, and short-term storage and retrieval from auditory memory. And then executive functioning, for people who don't know, is the ability to lead a self-actualized, goal-directed life. So it's hypothesis testing, self-monitoring, flexibility of change, cognitive switch, all of those. Okay, our inclusion criteria. Age, they had to be between 18 and 40, because that's your primary age of methamphetamine users. Education, we needed a baseline. So we used for pre-morbid intelligence, so we used a matriculation certificate, which is our equivalent of 12 years of education. Gender, men and women included, because methamphetamine is an equal opportunity offender. It does not discriminate according to gender. Like I said, 1 year minimum methamphetamine use and minimum 1 month sobriety. And those are our exclusion criteria, and it's essentially anything that had to do with affecting cognitive ability, including HIV status, because it can affect your cognitive rationale. And that's the data analysis we used. I know you're all very interested in it. We used non-parametric tests because we had a small sample size. We couldn't assume normality of distribution. And we used the Bonferroni adjustment because we analyzed our data repeatedly and we didn't want false errors. And our ethical considerations, because we were dealing with a very sensitive topic. We did have informed consent from everybody. There was confidentiality promised. There was anonymity. We didn't give cash incentives. We did go to the Professional Board of Psychology to get our ethics approved, and to the Human Sciences Research Council. They had the right to withdraw at any stage. It wasn't harmful to them. Everything was explained to them through every step, and they agreed to carry on. And those are the results. So that's a very brief look. Those aren't actually my people, but I just thought you'd like to see them. So this is a very brief look at our statistical results. That's the picture that you need to keep in your mind when you're looking through the tables I'm about to show you. So I'm not going to go through them all, don't worry, but that's our attention, our current users versus our recovering addicts. You can see we had some significant scores. Our current users versus our control group, only one significant score, which is interesting. Recovering addicts versus control group. Memory, we have a very similar pattern. And then when it comes to executive functioning, we have a very interesting pattern. Current users versus our recovering addicts. Recovering addicts always came out worse. Control versus our current users, absolutely no significant differences. There were no differences in these two groups in terms of executive functioning. And then recovering addicts versus control group, again, poor recovering addicts, once again, worse off. So, a graphical explanation is your brain and your brain on drugs. And here's the better one. So, as you can see, our control group is at the top, and that means that they had better scores overall than both the current users and the recovering addicts. However, interestingly, and what we didn't anticipate, was that the current users did better than the recovering addicts. In some cases, extremely significantly so. So even though the control group was better than the current users, which we expected, the recovering addicts in attention in every single test that displayed significance did worse than the current users. And the same pattern we found for memory. So methamphetamine is incredibly deleterious on your cognitive functioning, but for some reason the current users don't suffer as much as the recovering addicts. However, when we get to executive functioning, like I said, we see the control group and the current users, there is no significant difference. They are exactly the same in terms of executive functioning as each other. However, again, the poor recovering addicts suffer and they are worse off. And in this case, every single subtest of every test was significant. So recovering addicts are extremely deficient in executive functioning. So our conclusion, unsurprisingly, is that methamphetamine negatively impacts cognitive functioning in current and recovering users to varying degrees. What is interesting, however, is that recovering meth users experience the greatest cognitive impairment in comparison to both the control group and the current users in terms of attention, memory, and executive functioning. And we believe that this is because of the supplementational effect that the current users still have. They're still using methamphetamine. They're still stimulating the dopamine, norepinephrine, and serotonergic neurotransmitters in their brain. So they have a supplemental effect. They're still getting these neurotransmitters. They're still able to use them to process information cognitively. Whereas our poor recovering addicts have no supplementation. They're sitting in treatment with absolutely no methamphetamine in their brain, and because it's neurotoxic, they have physiological and chemical changes in their brain that make them unable to produce dopamine, norepinephrine, or serotonin to the degrees they once did. So, patients and facilitators can expect to find a significant increase in cognitive deficits relative to those experienced during use. And this has a negative impact on the desire to remain sober and the success rate of rehabilitation. People who come into rehabilitation as previous methamphetamine users are quite literally, in layman's terms, going to feel dumb. They're not going to be able to process information. Most rehabilitation information is presented in a visual format, in a pack. They sit in groups, they discuss things, they're expected to remember steps, they're expected to remember skill training, and they simply can't. All rehabilitation programs for amphetamines are based around cocaine, and methamphetamine and cocaine are not the same drug. In no way are they similar. They're both amphetamines, I'll give you that. They both have speed-like qualities. But methamphetamine is by far the most dire drug that exists around us today. So we can't expect rehabilitation clinics to be successful when the people that are going into them are unable to process information. So the current users versus the recovering addicts, again, the degree of neurological and neurocognitive damage is masked by the continuous methamphetamine use by current users. So the current users are still using, still stimulating their neurotransmitters, still able to function to some degree, not as good as the control group, thankfully, but again, not to the degree of the recovering addicts. And this means that until we change our rehabilitation programs to cater towards methamphetamine addicts and recovering addicts, they're never going to stay in rehab, and they're not going to have a successful rehabilitation, which means we're going to have a continued cycle of abuse. And just to prove my point, oh, there's my strengths and limitations. Sample size is small, I'm sorry, but it was privately funded, and it's very difficult to get individual drug users to talk to you. Polydrug use, we can't be sure that they weren't using other drugs at the same time, or if they lied to us about it. We can't be sure if they lied about their abstinence length, or if they were fully disclosing if they were HIV positive. We did do urine testing in the rehabilitation clinics, but you can't ask a methamphetamine addict to go give us a urine sample. They just won't do it. The generalization of results, because it was done in South Africa, it was done in Gauteng, the Eastern Cape, and the Western Cape. We didn't do all our provinces. We simply didn't have the funding, so it would be nice to do a complete countrywide study and be able to generalize that way. But the tests that we used were very well known, and they do have great reliability and validity. It's the first study of its kind in South Africa, and it's the first study of its kind worldwide to compare current users against recovering users. And then there is massive potential for future research, especially when it comes to rehabilitation, and it does question the efficacy of traditional rehabilitation programs. And to prove, there's a whole bunch of meth addicts. Yay. And that's it. If you have any questions, then we can do it afterwards.
Thank you very much.
Thank you.